Hello, my name is Dr. Minde. I'm going to continue the lecture series on the back. So in this lecture, we're going to start by discussing the joints of the vertebral column. So we have the joints between the bodies, joints between vertebral arcs, then we have the craniovertebral joints, costovertebral joints between the ribs and the vertebra, and you have the sacroiliac joints. So we will start with the joints between vertebral bodies. These are secondary cartilaginous joints, also called symphysial joints. And of course, body weight is transmitted through them and form between the end plates of the vertebral bodies and the intervertebral discs in between them. What are the functions of intervertebral discs? They provide attachment between vertebral bodies. That's number one, making the vertebral column semi-rigid. Then they form the inferior half of the anterior border of intervertebral foramen. So this is your intervertebral foramen. So the superior half is by vertebral body, but inferior half of anterior border is formed by the intervertebral disc. The IV discs account for 20 to 25% of the length of the vertebral column, and they permit movement of adjacent vertebrae. They also act as shock absorbers because they are deformable and resilient. They are composed of annulus fibrosus, which is outer concentric fibrocartilage layer, and nucleus pulposus, which is a gelatinous central mass. So the annulus fibrosus is concentric lamella of fibrocartilage forming the circumference of the IV disc. It usually inserts into the smooth epiphyseal rim of the articular surfaces of vertebral body, therefore forms fused annular epiphysis. The fibers run obliquely at right angles, and they form strong bond and allow some movement between adjacent vertebrae. So this is the annulus fibrosus, and this is the inner gelatinous nucleus pulposus. So this is the outer circumferential fibrocartilage that attaches onto the end plates. Nucleus pulposus is the central core containing 88% of water at birth and more cartilaginous than fibrous. It's usually semi-fluid, therefore giving flexibility and resilience to the vertebral column. They act as shock absorbers because they're able to deform, and the lamella of annulus fibrosus, they're usually thinner and less numerous posteriorly than anteriorly, and the nucleus pulposus is not really at the center, it's actually more posteriorly placed. Annular fibrosus is thinner posteriorly and less thinner and less numerous posteriorly. Nucleus pulposus is not at the center, is also more posteriorly placed. So nucleus pulposus is avascular. So how does it get its nutrition? Via diffusion. Okay, so diffusion from the blood vessels at the periphery of the annulus fibrosus and the vertebral body. Okay, so the IV disc, remember there's no disc between axis and atlas, and the most inferior functional disc is the L5 to S1. It's the most inferior functional disc, and the discs vary in thickness. The more weights you bear at the vertebral column, the more thick the disc will be. So the disc will be thick in the cervical and lumbar region to allow more motion, and they'll be thin in the superior thoracic region. So this relative thickness is related to the range of movement, actually. So in the cervical region, the discs are even thicker than the bone. Yeah, and lumbar region also has the thickest disc for high range of movement. So these discs, they produce a varying shape of the vertebral column, and this gives us the curvatures of the vertebral column. Remember, the discs are thick anteriorly in the cervical and lumbar region, and the thickness is most uniform in the thoracic region. Then we go to the uncovertebral joints. Uncovertebral joints are formed between the anchors of C3 to C6 vertebral bodies and beveled inferolateral surfaces of vertebral bodies superior to them. So the joints are lateral at the lateral and posterolateral margins of the IV discs, and the articulating surfaces are actually covered by cartilage with moistened by fluid. So these uncovertebral joints, we consider them as either synovial joints or just degenerative spaces filled with extracellular fluid. So uncovertebral joints are actually frequent sites of osteophytes of spar formation. Therefore, they'll give you neck pain. Okay, so the anchors of C3 to C6 vertebral bodies and the infrolateral surface of vertebral bodies superior to them give you the uncovertebral joints that are covered by cartilage. They are either considered synovial joints or just degenerative spaces. So look at this. This is the anchors articulating with infrolateral part of the vertebra above it. So it gives you an uncovertebral joint there. So this is the uncinate process. You can see. So as we continue discussing the union between vertebral bodies, you have to put in mind what you call longitudinal ligaments. We have anterior and posterior longitudinal ligaments. So if you're to look at this image, on the anterior part of the vertebral bodies, you have anterior longitudinal ligament that runs all the way through the vertebral column, and on the posterior part of the vertebral bodies, you have the posterior longitudinal ligament. Remember, you have your vertebral canal here. So the vertebral canal with the spinal cord passing here, this is your vertebral body. So this is anterior longitudinal ligament, and this is the posterior longitudinal ligament. Then remember, you have the spinous processes here. They are connected by interspinous ligament, and the tips of the spinous processes are connected by supraspinous ligament. The laminae of the vertebra are connected by ligamentum flavum. These are the laminae connected by ligamentum flava, interspinous ligament, supraspinous ligaments. So anterior longitudinal ligament is strong, broad, and fibrous, and it's on the anterolateral aspect of vertebral bodies and IV discs, extending from pelvic surface of sacrum upwards to C1 and occipital bone. What is the main function? It prevents hyperextension. Hyperextension is when you turn your head backwards, okay? Anterior longitudinal ligament prevents hyperextension of the vertebral column, and it's the only ligament that limits extension, okay? Posterior longitudinal ligament, on the other hand, is narrower and weaker, and it runs within the vertebral canal but on the posterior margin of the vertebral bodies and attaches onto the IV discs and less onto the vertebral bodies. So what are the functions of the posterior longitudinal ligament? It bridges fats and vessels between the ligament. There's a bridge of fat and vessels between the ligament and the bony surface, and it resists hyperflexion and prevents posterior herniation of the nucleus pulposus. It also contains pain fibers. So if you have, this is the posterior longitudinal ligament, this is your IV disc. So if the IV disc is to herniate posteriorly, the posterior longitudinal ligament prevents that herniation directly posteriorly. And then you can see that unlike the anterior longitudinal ligament that prevents hyperextension, this one is able to prevent hyperflexion of the vertebral column. Okay, and then it contains pain nerve endings. So what are the applied aspects? The intervertebral, look at the intervertebral disc. It can herniate. This is a normal disc. This is a disc that's degenerating. A disc can bulge. It can herniate. It can become thin or undergo degeneration with osteophyte formation. All those are age changes of the IV disc. Remember, nucleus pulposus, we say, mainly contains water, but with age it may hydrate and you lose the elastin and proteoglycans and gain collagen. It has more of elastin, but when you now lose it and gain more collagen, you affect its function. Then it can lose its turgor and become stiffer, therefore it deforms. So the nucleus becomes dry and granular, while the annulus thickens and develops fissures or cavities. The disc can lose its thickness, so you lose the trunk stature, and the disc height, as measured in the center of the disc, is normally maintained with aging. So you can herniate the nucleus pulposus. The gelatinous nucleus pulposus can protrude through the annulus. That's what we call slip disc, and that can give you low back pain or with lower limb pain, because as it herniates, it goes into the vertebral canal and compresses the nerves of that go to the lower limb. So when there's violent hyperflexion of the vertebral column, you can rupture an IV disc, okay, or you can compress an IV disc. Now remember, the posterior longitudinal ligament runs posteriorly here. So if you're to force this disc posteriorly, it will herniate mainly on the posterolateral because the posterior part is directly covered by posterior longitudinal ligament. So you herniate towards the spaces beside the posterior longitudinal ligament. And that's what this statement here says. Posterolaterally, annulus fibrosus has no support from the longitudinal ligament. So if the annulus fibrosus degenerates, nucleus pulposus herniates into the vertebral column posterolaterally, and that compresses the spinal cord and coda-equina roots. That's why you're having low back pain and lower limb pain, because these coda-equina roots are going to innervate the lower limb. So IV discs are largest in the lumbar and lumbosacral region. Therefore, remember also this lumbosacral region is where there's more movement. Lumbar have more movement and sacrum has no movement. So this junction is where there's that transition. So it's more prone to disc herniation. So L4, L5 and L5S1 are more prone to disc herniation. This is a normal disc, annulus fibrosus, nucleus pulposus. When annulus fibrosus degenerates, nucleus pulposus herniates, and this is the posterior longitudinal ligament. It's preventing posterior herniation, so herniation now occurs posterolaterally, coming to compress the spinal nerve roots at the coda-equina region. This is an MRI sagittal section showing you IV disc herniating and compressing the coda-equina. This is your spinal cord. This is coda-equina has been compressed. All this will lead to pain, low back pain, we call it lumbago, when you have protrusion of L5S1 IV disc. And remember, you have posterior longitudinal ligament that has pain fibers, so you feel pain, and there will be muscle spasm because of pain. The muscles will tense. Sciatica is low back pain and hip pain. Lumbago is low back pain. Sciatica is low back pain and hip pain. So that's the difference. Why is there back pain and hip pain? This pain actually starts from the back, but it radiates and shoots to the lower limb, so to the thigh, into the leg. Why? Herniated disc compress L5 and S1 nerve. Okay? When you compress L5 and S1 nerve, these nerves actually go all the way to the leg. So there's a decrease in size of the intervertebral foramina, and lumbar nerves increase in size as you go downwards. In the lumbar region, intervertebral foramina become smaller, but lumbar nerves become bigger. And the foramina, why are they smaller? They are being narrowed even some more by the osteophytes with age. So we have what you call Carnegie's maneuver. So the patient will flex the thigh with the knee extended, and that will cause stretch of the sciatic nerve, and it may produce or relieve pain. So that's the Carnegie's maneuver. It's done in patients who you're suspecting they have sciatica. So you tell the patient, flex your thigh with the knee still in extended position. That way you stretch the sciatic nerve and it may produce pain. Remember, the root value of sciatic is L5, L4, L5, S1, L3, L4, L5, S1, S2. Okay? So next we discuss the joints of the vertebral axis in the next lecture.